community. Let's see. Well, thank you very much for having me here. This is a real pleasure. I'm kind of a soft talker, so please tell me if my volume goes down. Just remind me, I won't be offended at all, I promise. And also, as questions come up, I would encourage you to just ask things as we're going through this. I'm hoping this is more of a conversational kind of topic. And it's sometimes you forget by the end, so I want to make sure you have all of your questions answered. So let's see, how do I click forward? Do you know how this moves forward? Here, I'll just do this. Oh, there we go. Okay. All right, so I'm going to do, I know we have an audience that is composed of families, some families with strong science backgrounds, some medical professionals, but I'm going to start at the very basics to make sure that we're all on the same page. So this is just a brief picture of the anatomy of the cell. And the reason I want to bring this up is because the mitochondria is one part of a giant machinery compacted in a very, very, very tiny package. So we have billions of cells in our body, and every cell has almost every single component that we see here. So here's the nucleus, the brain of the cell, and its job is to basically package our genetic material and participate in gene expression. We have here the ER, and that helps manage our molecules. It helps with stress response. It has a lot of crosstalk with the mitochondria. We have Golgi here, and they help modify our molecules in our cells. And the lysosome is responsible for waste disposal, among many things. And here, what we're here to talk about is this little mitochondria here, which is responsible for energy production. But what I'm going to emphasize as we continue to move through our discussion today is that the mitochondria, while they look like their own little isolated kidney bean hanging up out in there, they're actually they're in a constant crosstalk with the rest of the cell. And nothing within this cell exists in isolation. You're good. Oh, should I talk in here? Yeah. I like this one, actually. This is better for me. So in a constant crosstalk with the rest of the cell. So there's often this attempt to distinguish primary versus secondary mitochondrial dysfunction. But I think the things that are both intertwined and inseparable from one another. So when we get into further discussions about evidence for mitochondrial dysfunction in some diseases and not others, it is a very, very difficult thing to say for sure yes or for sure no, just because when a cell is affected with a problem, the entire cell is going to show its effects. So I'm going to keep repeating this over and over again as we talk to sort of explain how we think about conditions together as well as separately. So here's the mitochondria. And again, this is the way I think we commonly think of the way that it looks, sort of like a kidney bean with these little infoldings called cristae in the middle. Actually, in reality, this is not what mitochondria look like in this cell. We used to think it looked like this because we fixed things when we went to take pictures of them and we froze them and we took a snapshot, essentially. But really, mitochondria are these constantly moving, constantly interweaving and interwoven system of basically cellular communicators and cellular energy communicators. The mitochondria are responsible for producing energy, but they're responsible for a whole lot of other things as well. And we have here, it's a double membrane space. Here I'm going to give you a biology quiz at the end of this, so make sure you take notes. At the outer membrane here, is responsible basically for keeping out big proteins. And so it kind of is the first line to mitochondrial communication. This inner membrane here and all these foldings, this is sort of the business end of things. So oxidative phosphorylation, which you may have heard about because this is what we often think about when we're thinking about mitochondrial therapies, sits right on these infoldings and essentially works like an electrical circuit to produce energy. But there's a whole lot else going on inside here. Inside here, we process fats, we process certain proteins. It's responsible for the cell deciding if it's time to die or time to live. And it's responsible for telling other genes outside of the mitochondria when to express and when to say that they're stressed. So there's a lot of crosstalk going on. So as I mentioned, the mitochondria do a lot of things. ATP production. ATP essentially is our energy for the cell, the main source of energy for the cell. The citric acid cycle, the Krebs cycle, which is intimately connected to oxidative phosphorylation, so it passes some of the energy-producing particles over to the oxidative phosphorylation. Fatty acid oxidation is how we process fats. Transport of reducing equivalents, for the scientists in the room, this means a whole lot because this is how we think about the pH status of the cell. Apoptosis, that's when the cell decides it's time to die. And apoptosis, when I say the cell decides it's time to die, that is not always a negative thing. Our body needs a way to consider when cells are old and need to be regenerated. So apoptosis can be an important signal for that. So when I talk about this kind of process, it's not necessarily a negative thing. It's just another method of the way that the body and the cells speak to each other and communicate and decide how to grow and move forward. And ammonia detoxification, which is something that only occurs in the liver. And it's important for other groups of mitochondrial disorders that I see. But I think it's important just to know, again, when we're thinking of the mitochondria, we're not thinking of one thing. We're not just thinking of ATP in isolation. We're thinking of hundreds, thousands of molecules that are constantly in flux and communicating with each other. And trying to untangle what that dysfunction means and how to work with it is definitely an ongoing process in our field. I mentioned this a little bit. I think we talked about the structure, so I'm not going to harp on this issue too much. We'll move forward. So I'm going to step back a little bit and think about how we think about whole body energy and cellular energy. Our body is going through a constant process of building up and breaking down. Breaking down is something called catabolism, and that's when we use fuel to make energy. There's different places that we can get fuel. Fuel can come from the things that we eat. Fuel actually can also come from within our bodies. And we use that fuel and that energy to make the things that our body needs to grow and survive. And then there's anabolism. Anabolism is when we take those molecules and take those products and put them together to allow the body to grow. And this is essentially, if you think about it, as a scale that has to be met in the middle. We have to take in enough fuel to grow, to be able to let the body build up, but we don't want to take in too much because that can cause, obviously, a lot of health problems, metabolic problems, weight gain, things like that. So this is what all of our bodies are going through all the time. It becomes difficult to exactly assess what's going on in a situation where the catabolism and anabolism processes are undergoing some kind of stress, whether it's due to an intercurrent illness like a flu or a virus, or whether it's due to a metabolic or genetic condition that changes the balance of this careful balance that our cells and bodies are going through. So let's talk a little bit about where energy in our bodies come from. Energy in our bodies, within our cells, comes from a couple of places, actually. We tend to think of mitochondria as the first and most prominent place that energy comes from. I'm going to talk about that first, but it's not the only place. So this is that respiratory chain that I spoke about earlier that sits on those infoldings of the inner mitochondrial membrane. And it's pretty cool. It functions essentially like a typical electrical circuit. So I don't know if we have any electricians or electrical engineers in the room. How our mitochondria essentially create energy is passing charged particles to create a charge gradient along a membrane and shoot one of those charged particles through to create the power of ATP. ATP is essentially, again, our energy molecule. Now, how does this respiratory chain get charged? Right here. It gets charged from exogenous and endogenous, the things that we eat, and the things that come within our body. Carbohydrates, fats, and proteins feed into this process. And we efficiently make ATP. Now, how we continue some of the energetics of this process is you can see the little negative E, the E negative, and the little star. That's a charged particle, an electron, or an oxidant that gets passed along that inner mitochondrial membrane to create that energy. So I want to emphasize here that when we talk about charged particles and oxidants, it's not something bad. It's something that our body needs and requires in order to produce that energy. The concern that we think about in mitochondrial dysfunction is if these charged particles go to the wrong place. That's when we have to consider can damage be ongoing. Okay, so we always think of oxidants as bad. They're not bad. If we didn't have them, we wouldn't be able to power our mitochondria. It's just where they are is something that we have to consider. Does that make sense? Okay. But as I mentioned, again, and I promise you, you're just going to hear this again and again and again. If you take one thing away from this lecture is that nothing is in isolation. I'm used to having students. So that if we look here at our mitochondria, everything, energy products, charged particles, everything is moving in and out of the mitochondria in a constant flux. And again, nothing is in isolation. Where else can energy come from? Well, there's a couple of situations where oxidative phosphorylation is not working optimally or can't keep up with the needs of the body. When that happens, the cell turns to another primary source of ATP or primary source of energy, and that's called glycolysis. And essentially, you use exogenous from the things you eat and endogenous. These are things that your liver breaks down, glycogen, to make glucose. And glucose, when it's broken down, can produce 2 ATP molecules, each molecule of glucose. This is paltry compared to the ATP that the respiratory chain can produce, but it is certainly a source of energy that the cell can use and use well. Have any of you heard of lactic acidosis, lactic acidemia, lactate? That's a common thing that comes up, right? It's a common thing that we hear about, particularly with mitochondrial diseases. Lactate is not a bad thing. Where we think about lactate is what does it mean for the cell? In situations where oxidative phosphorylation, that respiratory chain, might not be producing enough of this ATP or this energy molecule, this process gets upregulated, but you get all of this extra pyruvate, which itself is turned into lactate. So that's where lactate's coming from. Okay? So lactate itself, the thing of lactate, is not harmful. The reason that we worry about lactate is because what does it mean for the energy supply of the body? Okay? So, for example, I have patients who have other kinds of mitochondrial diseases that will carry a baseline lactate of 10, which would be very, very, very scary if we didn't know where it was coming from. And this child is able to produce enough energy through her glycolysis that we don't worry particularly about that lactate. Does that make sense? Yeah. Another common mechanism, actually, for this kind of lactate production would be in cancer cells. Cancer cells do not use oxidative phosphorylation very well, but they use glycolysis very well, and they're able to survive. But as I mentioned, everyone's talking to everybody else. It's just it's a constant conversation in our body. So when glucose is broken down, you get your 2 ATPs, but then these 2 molecules of pyruvate, if your mitochondria are doing what they should be doing optimally, take in that pyruvate and make ATP through the respiratory chain. And this is meant to be the cytoplasm of the cell, and this is the mitochondria of the cell. So we're done with our biology lesson, and we're going to move forward into what this means physiologically. But I just want to pause and just see, are there any questions from what I said so far? Anything at all? Okay. So when we think of energy failure in the cell, what we're really talking about is the cell is not producing enough ATP, that energy molecule, to do its functions, to do the needs of the moment. And if you think about it, we have different needs of the moment depending on whether we're sleeping, whether we're awake, whether we're running a marathon, whether we're sick, whether we have a flu. So energy failure means very different things during very different times from day to day and throughout the life cycle. When somebody is undergoing a massive growth spurt, they have different energy needs. So when we're talking about energy failure, we're saying at that time, the cell and the mitochondria are not able to produce enough energy to adequately power themselves. When this happens, the mitochondria send signals out to the rest of the cell and say, we don't have what we need, something has to change. And that's called cellular cascades. Dr. Fatimi had mentioned stress responses. This can actually be a very strong trigger for a stress response when, again, the mitochondria is saying, I don't have what I need. The rest of the cell has to react and compensate for that in some way to allow the cell to survive. Part of that process is increased. ROS is basically oxidative species. So I'll just say ROS for oxidants. And those oxidants cause damage, but they also cause signaling. And actually, it's through that damage that they cause signaling. So those oxidative species, those oxidants, will actually get into molecules like fats and proteins, change their structure, and that structure signals the rest of the cell to say, something's wrong, I have to react to this. Okay? In the process of sending that signaling, of course, then those molecules themselves are damaged. So what are the problems with the cell that oxidative damage can cause? Well, as I mentioned, one of the problems is this ROS response. So there are certain parts of the cells that see these oxidants. Iron sulfur centers are a very important part of that electron transport chain. So the electron transport chain is releasing those oxidants, but it's also being signaled back by them and undergoing changes. And this reaction decreases the mitochondrial energy production. So what your mitochondria say when they receive oxidative stress is, I have to shut down oxidative phosphorylation. I have to shut down my most efficient energy production because it's damaging me. It seems almost it does feel counterintuitive, doesn't it? But it's saying, stop damaging me. Stop sending these molecules through. Let's slow down a little bit. And as I mentioned, chronic oxidative or oxidant exposure, and this is in any form of mitochondrial dysfunction, whether it's a mitochondrial disease, whether it's other reasons for oxygen deprivation, can eventually lead to permanent damage or ongoing damage of proteins, lipids, and our genetic information of the cell. And some of the things within our cell that is thought to be protective against these escaping oxidants are things like thiols, glutathione, various vitamins, and we're going to talk a little bit further about some of those thoughts. So just to let you know, all of the things that oxidative stress contributes to is accumulating injury to lipids. These are the membranes of the cell, the things that hold the cell together, accumulating organelle damage, alterations in cellular survival. And it, again, changes the way the cell is thinking. There are changes in signaling throughout the cell and changes in the way that genes are expressed in the cell. And I have a nice little cartoon here showing basically how some of these oxidative species can react with some of the protective mechanisms in our cell. So there are ways through things like glutathione that our cell can try to protect itself. And this is something that we really want to think when we think about how we can approach these diseases and these conditions and these dysfunctions. Can we somehow tamp down some of this oxidative stress? Can we capture some of these harmful or overexcited oxidants to allow the cell to calm itself down, to bring back some of that cellular stress, and to move forward with energy production? And here's a nice little picture showing what our cell internally does. Oh, there goes my picture. It's still gone. Okay. What the cell does internally to try to protect itself. So we take our cues from our body. We take our cues in therapy and approaches to diseases from what our body already does in order to protect itself. So when our cell is overcome with these oxidants, as they're listed here on the right side, it upregulates antioxidant defense systems. And among those things are superoxide dismutase and catalase, which exist within the cell, glutathione, vitamin C, vitamin E, and other antioxidants. And so our approach to this is, if this is what the cell can do to protect itself, can we shore this process up? So that's sort of the whole thinking behind these mitochondrial medications, cocktails, things like that. Let me pause, and then we're going to get into some basic principles in management. So what I'm going to talk about right now is sort of the principles of how we think about these things, not specifically my recommendations for treating disorders. I just want to be very clear about that. I want you to understand everything that we're thinking and what our thought process is, and I'm happy to answer any questions at the end, but this is sort of basic principles about thinking about mitochondrial dysfunction and treatment. So I think what most of us would agree upon who are within the field of mitochondrial medicine, and you may have seen this before, so I'm going to just sort of pause. I always tell families every time they see me, if you see 100 different doctors who specialize in mitochondrial medicine, you're going to get 100 different opinions about what the right mitochondrial cocktails are, what the right therapies are, what works, what doesn't work. And when that happens, that's because there is no right answer yet. Does that make sense? I want to keep emphasizing that. When nobody agrees with anybody, it's not because everybody's not thinking, considering, trying to solve things. It's because there's not an accepted practice yet at this time. So everybody's sort of working on their own best principles and best judgments. That being said, some of the accepted principles in this field are sort of approaching bioenergetic stress from two different directions. The first one is to try to reduce these oxidant species in various different ways, whether that's sort of reducing the stress on the cell, providing antioxidant therapy, providing cofactors to help the respiratory chain work better. That's one piece of things. The other piece of things is to try to keep the cell or the body from reaching that threshold where it has energy failure. Right, so I mentioned energy failure, for the most part, isn't just a constant thing. It's something that occurs when the body needs more energy than the cells can produce. So what we try to do is even that out a little bit. How can we make sure that the body is functioning and doing everything it needs to do, but without going over that threshold? And we all have a threshold. I mean, I couldn't run a marathon. I would collapse halfway through. And there are some people who could run a marathon, and there are people who can run ultra marathons. So we're dealing with sort of a normal curve of energy threshold, and everybody has one. It's just when you have a condition that affects the way the cell function, it shifts it towards the side when stress occurs earlier. So what we want to try to do is think about ways to keep people from hitting that level of just too much stress. And these are some simple principles that I'm sure everybody at this point is following already and have already intuited on their own. Avoid prolonged fasting. When you starve the body, when you're not supplying the body with glucose and protein and fat, your body turns inward on itself and starts chewing up its own tissues. Have you ever had the flu? And your muscles really start hurting at the end and they start aching and you're feeling kind of crummy and it takes a little while to get back to yourself? The reason is because you're not eating, you're not feeling well, and you need lots of energy. So your body starts breaking down your muscles to get that energy. So what we want to avoid is the body having to use its own internal sources of fuel to make this energy. So we avoid fasting. Okay? We avoid fever. I trained as a pediatrician, so many years ago. In my early days of pediatrics training, we always said, let kids run a fever. Doesn't matter. It's part of the way that they deal with illness. And that's true. Sorry, I'm on call. I really apologize for this. Let me just... Okay. Where was I? No, it's all right. I have a fellow. She's dealing with it. Thank you, team. Avoiding fever. So we used to say, don't worry about kids running fever, but what a fever does is it increases your basal energy expenditure. The cell needs a lot more energy to function in the setting of a fever, and fevers are fine in some situations because the bacteria can't function so well in that high temperature either, and that's how they know to, that's how the body responds to these illnesses. However, when you already have a reduction, thank you very much. When you already have a reduction in the amount of energy that your body can produce, you want to avoid having to increase that basal energy expenditure. So generally, I don't recommend that individuals who have primary or secondary mitochondrial dysfunction be allowed to run fevers too long or too high, or frankly, any fever. So we usually think of fevers higher than 100.4. And the reason for that isn't because of the infection. The infection still needs to be treated. It still needs to be attended to, but because of what that does to the body's energy needs. We certainly don't recommend using Tylenol or Motrin more than the recommended doses. You always do with the doses on your bottle, but we avoid fevers, okay? We avoid dehydration. Yes?
What's too long? You said you don't recommend...
So I recommend bringing a fever down once it hits 100.4. Mm-hmm. Some kids with mitochondrial conditions, and I don't know if this is true for LBS cells, you all have to tell me, tend to run lower body temperatures in general. So those families will tell me what their child's fever threshold is. So I have some families who will tell me my child always runs a 97 Celsius. Once they hit 99, it's a fever. And so I go by what the family tells me. There's a lot of give and take with families, and we try to really rely on that. Do you have the experience that generally body temperatures run on the lower end? Yeah. Yeah.
7, 9, or 8 is Ellie.
Yeah.
My other daughter's 80 or 90.
Yeah, and I think that's not an uncommon thing sort of in the mitochondrial primary or secondary realm. And so if your child is running a 97 and for you a 99.5 is a fever, then that is what you would want to treat at. Standard is 100.4. Yeah.
In Brazil, for physicians that treat mitochondrial disease,
Mm-hmm.
that's how you pronounce it, they do not recommend giving Tylenol. Any specifics, they have Tylenol, they have ibuprofen, but they have another medicine called Dipirona. I don't know how it's equivalent.
Not sure.
But they don't recommend Tylenol. Is there any reason you think?
Yeah, so the reason for that is because there are some of the more common mitochondrial conditions have a component of liver dysfunction, and Tylenol really can have an effect on the liver. Large doses of Tylenol produces a lot of oxidant stress to the liver, It's something to be considerate of. On the counter side, and this does not apply to LBSL, but in general mitochondrial conditions, a lot of those patients can have an aspect of kidney disease, and Motrin can affect the kidneys, and so then we would choose Tylenol instead. So it is really, really very dependent. Mm-hmm. Mm-hmm.
So with fever management from a parent perspective, again, many of you probably know some of this, but we start with ibuprofen. I think that has an 8-hour span in the children's version, and then acetaminophen or Tylenol has a 6-hour span. So if we're in a pattern, if Vivian, our daughter that doesn't have LBSL, gets sick first, and we know it's a heavy fever item, we get out in front of it and go, we cycle them, because I'll ask the neurologist in the room that they hit different parts of the brain when they want to control fever, so you can use them at the same time.
You tell me. I mean, anything I can learn. And this is something we all should be doing, so this is for all of us, is a balanced, healthy diet, which we all know is far easier said than done. It is also far easier said than done in 2-year-olds who don't want to eat things, or teenagers who want to live on white rice, like my teenager. And so even I have a difficult time with this. But it is important to, if you have a pediatrician or a primary care physician who's willing to work with you, they're very busy folks. It can be really difficult, or a dietitian who's willing to work with you, or your friendly geneticist or neurologist, to make sure that growth curves stay on track. That doesn't mean everybody has to be 99th percentile for height or weight. It doesn't mean everybody has to be a giant. It has to mean that that kiddos and adults with these conditions aren't falling off the growth curve. And that's really important. We want to get really far ahead of that. As soon as we see things start to dip, the interventions don't have to be big, but we really want to try to stay on top of that. When the body's deprived of energy, even if the child currently doesn't have an illness, it can be very difficult to handle intercurrent illnesses when you're nutritionally deprived. So where do the vitamins act? So I'm going to talk a little bit about some of the common vitamins and supplements that are recommended in general mitochondrial conditions. And I'm not saying this to be waffling or evasive or a fence sitter or anything like that. It really is because depending on whom you see, they may have different recommendations for you. But the important thing is to know why those recommendations are being made, what they mean, and in what part of the cell do they work. So that there should always be some sort of logical thinking about what you're being recommended, why that's being recommended, and what the thought process is behind that. So one of the more common vitamin supplements that's recommended is something called carnitine. And this is something that I do often recommend, or at least make sure it's not depleted. The reason for that, because carnitine is a very important molecule for helping the mitochondria to use fat. And fat is important, obviously, for energy production. So if someone is carnitine depleted, which sometimes we see in kids who aren't able to eat well, don't have a great diet. We see in vegetarians. My carnitine is probably a 7. But it's important to make sure that it's not low, because that helps feed fat into the respiratory chain. Some people, some physicians may recommend coenzyme Q10 or succinate, because coenzyme Q is a carrier within this mitochondrial chain. Succinate can feed into as an extra fuel into the mitochondria. Coenzyme Q is also an antioxidant. And what are antioxidants? Antioxidants are meant to capture these charged particles when they escape and go to the wrong part of the cell. Try to reduce some of that signaling cascade that has the cell saying, I'm really stressed out, has the cell saying, I'm going to turn down oxidative phosphorylation, and has the cell saying, my molecules are feeling damaged. So some well-known antioxidants are vitamin E, lipoic acid, and acetylcysteine, and coenzyme Q10. Talk a little bit about the controversy in some of these things. The main controversy is that we don't know that when we take these things into our mouths, are they getting to the places that they need to get in order to tamp down this oxidative stress? We know that cells with mitochondrial dysfunction have oxidative stress. We know these vitamins, when looked at in a petri dish or within our own cell, contact these oxidants, it reduces them. What we really, really don't know quite yet is when we put these things into our mouth, does it make it to the mitochondria to reduce that stress? And that is really, and I'm going to talk a little bit more about that, but that is really where a lot of the current controversy in this kind of approach to mitochondrial medicine exists. Oh, and some folks, depending on which mitochondrial facility you see, some folks really do believe in using creatine, which is thought to help improve the ATP pool. So I just wanted to also get that part in there. I'm trying to cover everything that you're mostly recommended. And if there's anything I haven't covered at the end, we can certainly go back and try to fit this into this picture.
Can I have a question?
Yeah.
How about crossing the blood-brain barrier if the problem is in the brain?
Yeah. That's my last 4 slides because I knew that was going to, it's a big question. And that is also part of this controversy. We don't know what's getting across. We really, really don't know. But I will definitely get there. So why is this field so controversial? So there are few to no standard protocols for supplements for many, if not most, mitochondrial conditions. I'm getting away from here. So there are some mitochondrial conditions where the primary dysfunction, the primary problem is the patient does not make enough CoQ10. That's easy peasy. We supply CoQ10. Where this becomes much more complicated is in the vast variety and multitude of mitochondrial conditions where there's not such an easy target for improvement, outcome, or measurements, and there are, again, few to no standard protocols. There are few to no well-controlled studies on the effects of individual supplements. And there are a number of reasons for that, and I think Dr. Fatimi had sort of touched upon nobody's doing anything wrong. It's just that these conditions are individually so rare and so varied, it is so difficult to design a clinical trial where you have an appropriate endpoint that you're going to prove anything. This is a real difficult issue in mitochondrial and in rare disease medicine in general. I think we're getting there. I think people are really working on designing these studies well. And so, again, it doesn't mean that these things are wrong. And when I talk about, or these things are wrong or that there's no evidence, it's just when I sort of talk through these kinds of therapies, the sort of accepted burden of evidence one would require for a common medication, something like a statin for high blood pressure or something like that, does not exist for conditions like this. Okay. This was the question that Paul just asked, as well as something that I just touched on. It's not clear that these supplements get to the affected tissues. So it's not clear that the cell takes it in and puts it on the mitochondria. It's hard that, remember I mentioned the mitochondria have that outer membrane that keeps big stuff out? So we're not clear exactly what it lets through. We're not clear that what, if anything, crosses the blood-brain barrier. And we're not clear even that it's getting to other affected tissues all the time. But I don't want to get too down on this because I do prescribe these things, and there's a reason that I do, and we're gonna get to that next. But most clinicians will rely on their personal experience. I talked a little bit about evidence in clinical investigation. I was sort of forewarned, but I got an email about this. Will some doctors say, I will not do this, I'm not going to do this, I don't believe in this, I'm not going to prescribe this, it doesn't make sense. It's because of these pyramids of evidence and clinical investigation that really exist in our field, and for very important reasons. So when you think of the most powerful information that physicians and scientists use to think about whether a drug is worth the risk-benefit, this is what this pyramid looks like. The way top blue triangle is called a meta-analysis, meaning there have been multiple controlled placebo studies showing a significant effect. Right? There are actually not a whole lot of drugs for which we have this kind of evidence, but this is considered like the gold standard kind of evidence. Then there's systematic reviews. People take all this data, put it together, and write a very nice review that includes clinical trials and personal opinions and things like that. Then there's randomized control trials. This is what we're all trying to get to with rare conditions, because once we get there, we will have a really clear, nice level of evidence about what we're doing. Cohort studies, following groups of kids to see how they do on certain, or adults, we're not all kids, on certain medications. Case-controlled studies. So historically, looking back and seeing, do kids on medication do better than kids not on that medication? Then we're getting into the kind of evidence that we really have in mitochondrial medicine. We're moving to the bottom of the pyramid. And again, this is not for every condition and every supplement. I'm talking about the vast majority of things. Case reports. So we use a lot of case reports. So when part of what we send is whole, and I'm telling a lot of anecdotes, but I'm hoping that this is illustrative to how we think about these things. When I send a whole exome on a patient and get back a gene that has been reported in 5 children. And what do I know? How do I tell the family? How do I tell them where to go next or what to do or what to think? We go to the literature and look at these case reports and say, these 5 physicians have thought through this patient. This is what the patient's problems were, and this is what seemed to work for them. And if that is the only evidence I have, and that is all I have to offer the family, and we're thinking through together why we're doing this and how we're doing this, then that's what we're going to go with, right? We have to go with what we can offer within a well-thought-out manner. And then background information and expert opinion. We all have an expert opinion. We all think we're experts. And we're all going to give you our opinion. I just want to emphasize that what most people are telling you are their opinions, and they may very well be expert opinions based on excellent background experiences. Okay. So I think there are very few hard and fast facts in this field, but everybody's giving you their best and most well thought out opinion. Okay. So I touched on this, but why is it so hard in rare conditions and in mitochondrial conditions to gain these highest levels of evidence? I recently gave a congressional briefing, just sort of emphasized the importance of funding for rare diseases, because rare diseases are very, very approachable for therapies. We just need to think through about where the holes are, the gaps are in terms of getting these clinical trials and how we can prove effect. So this is really why some of these mitochondrial therapies have not reached that highest level of evidence. Small cohorts. So mitochondrial conditions are common as a group, but individually are very rare. So when we think about what natural history has been established, we're often talking about a handful of patients, although I think Dr. Vandernap, is that her name? Is that her? She's put together just some beautiful reviews on this condition. So I think here there's been some very nice longitudinal histories. There's difficulty in determining clinical targets for treatment outcome. And this is twofold. The first is when you have a condition that has long-term life effects, it can take a very, very, very long time to see a change in the clinical status when you're approaching that condition, right? So if you expect to see a change over the course of days, then that's easier to measure. But if you're looking for a change over the course of years, that takes a long time. The other thing that's common in every condition, but particularly in a lot of the mitochondrial conditions, is that there's a wide variation in how severely patients are affected, and that really changes your endpoints. So, for example, the clinical trial that I'm working on right now in Barth syndrome, we're focusing on the endpoint that we selected is 6-minute walk test. I have a good proportion of patients who can't walk. They can't participate in this trial because we need this endpoint. So you have to be very careful about designing these studies up front. There are few to no biomarkers correlating to clinical status. How do you measure things to know if someone's actually getting better? But I just want to say, again, to emphasize, because I'm not meaning to be a drag, I'm very, very positive about the direction that these things are going. These issues are not insurmountable. They just have to be considered very carefully. So my personal approach, right, getting to sort of the end of things and the part where it's a little more subjective. So my approach to these kinds of supplements, my approach to medicine in general, is first not to do any harm. Right, so the first question I always ask when I'm thinking about an unconventional therapy or a therapy that doesn't have the highest level of evidence is anything, and I'm sure this is the first thing that comes to all of your minds, as parents and family members, is this have any potential harm to my child, right? So if anybody offers you or recommends to you something, that's the first thing to ask, right? That being said, my next principle is to keep an open mind. So I don't even think I know best. I think I know things, but I know there are other people who know things too. And so when families come to me with, you've recommended this, but I've read about this, and I've thought about this, and I've heard about this, and my friend said this, and my colleague said this, and I saw this on Facebook, well, we look into it together, and we think about it together, and we think about what the possible risks and benefits are. Right? And so when you go home and you're thinking about the physicians that you're working with and the physicians that you're dealing with, I really think open-mindedness is incredibly important. That would be sort of it's always sort of a red flag for me if someone is so narrow and not willing to think about anything outside of their own opinion. And then I ask myself, and I'm sure you all do as well, is there a risk to this approach? is there any level of evidence? To me, it doesn't have to be a meta-analysis. It doesn't have to be a randomized controlled trial. It doesn't have to be a case control study, but is there any evidence that this thing may help? Has this approach worked in similar conditions? So if we don't have evidence in a condition, in LBSL, has it worked in something similar? Has it worked in HBSL? Has it worked in any of the other tRNA synthetase disorders that have effects in the brain? And then the next thing that's always important is, does this child have an improvement with this approach? I mean, families know best. If a family tells me, this worked, this looks good, I think this helped, that is a very, very strong piece of evidence to continue moving forward. Likewise, if a family says, this isn't helping, this didn't do anything, I don't see anything, we've been doing this for months and I don't know, we don't have to stick to that either. We can try other things. All right. So this is sort of a process in flux, trying to find the right or best approach. And then sort of where I go with these supplements. So I really do aim to keep key vitamin levels that in a robust range. So I don't know if I give someone a whole lot of vitamin E or a whole lot of CoQ10, is it getting to that mitochondria? What I do know is it's not good for the cell to be depleted of those antioxidants. We have accepted normal ranges on laboratory values for vitamin E, for CoQ10, and for carnitine. And so my best principle is that these things should be kept at the highest end of normal or right above normal. No one should be taking gallons of supplements. I see these pictures on the internet of people who have like 20 bottles of supplements and they're, I don't even know how they have room in their stomachs for food, frankly. But these are sort of the first principle when I think about these kinds of antioxidants, because I can measure them, because I know they're safe, and because I sort of have an inkling of what they do. Supplements. Any questions? Let's pause here for questions on supplements and move into a little bit of a different area. Okay. All right. Approaches to bioenergetic stress reduction. And I mentioned this. This is when I provide emergency letters to my patients, this is sort of the guiding thing that I put in those letters, because I'm sure that you find yourself having to explain your or your child's condition to physicians when you go see them. And that can be, really puts the burden on you of trying to explain to people what they need to do for your child when you're going to them for help and in a worrisome and an emergency situation. So what we do is try to provide a letter to offer some guidance, to try to shift some of the burden to us being the teachers. And that is explaining what the condition is and explaining the importance of general health strategies, optimizing nutrition, making sure that calories are well proportioned, following growth curves. The patient should have appropriate sleep. I think that patients know how to listen to their bodies, and so I always include in that letter, do what you can, but don't do more than you can. Move if you can, do what you can, but if your body's telling you I am out of energy and I need rest, then that's what you do. Precautions during surgical procedures, this is especially important. Surgical procedures are very stressful for a number of reasons, and the biggest reason is because they tell you to stop eating at midnight, and then you go in for your surgical procedure, and then you're going under anesthesia, and they're cutting your body open and causing all kinds of other stress. I know that sounds very crude, but that's what physicians think of surgeons. So we bring our patients in the night before and start them on dextrose. This is for every patient I have with a mitochondrial metabolic condition, because it's not going to hurt and it's as safe as it can be. Bring them in for IV fluids with a little dextrose in, starting at the point when the patient is fasting, so that we're not depriving them of energy, so that they can go into that surgical procedure in the best energetic status that they can be. It's a general principle, but it's something that we surprisingly sometimes have to fight about. Avoid continued deprivation, so avoid fasting. And this is patient to patient. For some kids, fasting overnight is too long. For some kids, overnight is fine, but we don't want to go longer than that. And it is, again, very, very patient-to-patient dependent. And optimize muscle strength and avoid deconditioning. So this is a do-what-you-can kind of thing. So I recognize that myself, certainly, but many of my patients are not going to be able to be marathon runners. They're not going to be able to participate in high-level athletics or maybe build up a whole lot of muscle. But it is a lot harder to build up muscle that's been deconditioned. It puts a lot of stress on the body. It requires a lot of energy to build muscle. And so what I recommend is staying as conditioned as your body allows you. To the point, actually, that when I have patients who come in critically ill to the intensive care unit, I'm on call right now, so it's very prescient, we actually bring in physical therapy the day that they come in. Even if the patient can't move, even if they're intubated at the time, somebody is moving those muscles and keeping them going. And so I think the folks at Hopkins now are used to me saying, why are you calling in physical therapy for a child who's intubated? And this is exactly why. I want to keep them moving. All right, let me pause there and get into some considerations. But again, this is considerations, not specific recommendations. Does that make sense? Because recommendations, as I hope that I'm expressing to you, are very, very, very person-specific, right? Specific to the child, to their, or the adult, to their abilities, to their needs, to their health status. So I think that this is a very reasonable question. And this is something that's been posed it's been posed in LBSL. It's been posed in quite a number of primary and secondary mitochondrial conditions. What is the evidence actually that the mitochondria is the problem? And I'll give you my thoughts on this. So there is some robust evidence that decompensation in LBSL and other conditions like this can occur early and in the setting of bioenergetic stress. It's pretty well documented that the kids can have real problems, particularly when they're young, associated with a big GI bug, associated with a big fever, associated with some dehydration. And that link to bioenergetic stress for me is enough to say the mitochondria are being affected here. Again, whether that's the primary problem or the secondary problem, it's enough to say there is some kind of stress going on in the body that we need to mitigate at this time, and we need to do it in the best way that we can. We can get into the literature. So that's my sort of clinical spiel. That I think that, I don't know if it's a primary mitochondrial problem. There's certainly evidence that talks about that the cell itself is dysfunctioning, but certainly clinically we have the evidence that stress contributes to the problem, and stress is a mitochondrial issue. There is some very nice experimental evidence, and for any of the scientists in the room who are interested in this paper, it came out in 2014. I'm blanking on the name of the authors, but they showed that when you remove the DARS2 gene from cells, they actually have two kinds of stress responses. One is actually the mitochondria themselves aren't working so well, and then there's also an independent stress response going on in the cell, but that there's a lot of crosstalk between those two processes. So remember how I said if something affects the rest of the cell, it affects the mitochondria. If something affects the mitochondria, it affects the rest of the cell, right? So we're just trying to deal with what we can here. So tissue specificity in LBSL. Because this is a CNS disorder, does that mean that the mitochondria are only affected in the brain? Well, this LBSL is one of many, many genetic mitochondrial and metabolic conditions that have only CNS effects. They're both mitochondrial and non-mitochondrial conditions in both primary and secondary mitochondrial conditions. So in my thought process, the fact that it's isolated to the CNS does not exclude it from being a condition that has important mitochondrial dysfunction in it. So I hope I'm sort of trying to answer all the questions that sent me. So I'm making sure I kind of cover everything. But it's not understood why this is. It might be because different tissues have different energy needs. It might be, I think that's unlikely. Your heart needs a whole lot of energy, but in this condition it seems to be the brain that's affected. It's possible this is due to tissue-specific stress responses. There are different signals that tell the brain I'm unwell, then tell the heart I'm unwell, then tell the kidneys I'm unwell. And that might be some of what we're dealing with here. But this is certainly a rich area of research, of ongoing research, and a lot of thought about what makes one tissue more susceptible to this kind of dysfunction than the other. And I don't think we're there yet. But I think that people are certainly thinking hard on this kind of issue. But to just sort of a last overview about why I still think that these issues are incredibly important in conditions that are isolated to the CNS and in which may be primary or secondary mitochondrial stress responses is because our body chemistry is talking to our brain all the time. And our body sends stress signals to our brain all the time. And here, when we're looking at that blood-brain barrier, here we're showing things that get across into the brain. you can see that inflammatory signals themselves crosstalk into the brain and send a lot of stress signals through. Our body sends our brain its glucose. Our body sends our brain its amino acids. And so if we want to make sure that our brain is in the best health it can be in terms of its fuel and nutrition, our body needs to be as well. Okay? So I take a similar approach to my patients with LBSL and related conditions, is reducing the stress of decreased fuel, avoiding prolonged fasting, surgical precautions, avoiding fever, avoiding dehydration, maintaining a balanced, healthy diet. And I discussed reducing stress of ROS through antioxidants at a physiologic level and oxphos cofactors, but also being as open-minded as possible to whatever's going on in the community, to whatever's going on with families, to whatever's being recommended by other physicians, just taking sort of a careful and reasoned approach to what we're doing. There we go. Well done. Any questions? Yes.
When you talk about prolonged fasting, what is prolonged fasting?
So, children over the age of 12 months, if they can tolerate it, overnight should be fine. But there can be some, again, nutrition is such a particular thing, child to child. There are some signals that we hear that if a child is waking up very slow, very cranky, very difficult to move, then we do consider that overnight they're energy depleted. And so we may consider things like taking preventative measures before they go to sleep, supplying some extra energy. Some families go to G-tube overnight if that's too hard for them, depending on the condition. I mean, it really is very child dependent. I sort of take a careful cue from my patients. If there's a child who's 2 years old and still waking up in the middle of the night for a bottle and has a condition like this, it's not behavioral. It's because their body's telling them they need energy. And it's so those kinds of cues and signals that the children are giving us that help us think about what their tolerance should be. No longer than overnight, though.
And the follow-up to that is, what is the best method to get whatever energy it is into them?
Yeah.
Instead of like a huge meal before bed.
So this is not controversial for me, but this is definitely controversial depending on who you see. Some people will recommend a cornstarch supplement before bedtime. Cornstarch, uncooked cornstarch, is a supplement that slowly releases glucose into the body. The intestines break it down slowly, so it keeps the body from going into catabolism, breaking itself down, for a few hours. It puts that process off. Children under 1 cannot have cornstarch. Their pancreas is not ready to break it down. So it's something that's a little bit is for older children. So that would be one way to think about it. Certainly G-tube, I never, ever, ever, ever think of G-tube as a failure. G-tube is a tool. So if a child needs it and it helps them get their nutrition and the cornstarch isn't doing it, then that's what we think about. And like I said, sometimes kids, if they wake up overnight and have something to eat in the middle, have a bottle in the middle of the night, and we're careful of their teeth. I'm a pediatrician. We don't send babies to bed with bottles in their mouths. There's very different approaches. And it's just something to really think about, as a sort of a team approach with your physician.
Dr. Vernon, on that, with Kelly, she was on cornstarch from age 3 to, I want to say, 5 or 6.
Mm-hmm.
But I thought we were told, I believe, that she reached a weight where there wasn't really going to be an impact from the cornstarch. Is there a range there that's appropriate?
I don't have any specific cutoffs. And that is certainly true. When you attain a certain size and weight, your liver grows with your body, and it has a whole lot more reserve. There are certain metabolic conditions where your body can't make that reserve. LBSL is not one of them, in which they need cornstarch their whole lives. So.
I have a question, but I just wanted to say also that when Ellie was 3 and we started there was like a teaspoon of cornstarch that we put in her milk, she would wake up in the morning less shaky. So for whatever that's worth. And then I got to a point where I felt like we didn't need it anymore. So we kind of worked that out on our own. But anyway, my question, and thank you for this wonderful presentation. I feel like I know so much more now. My question is there a difference between the mitospectra, which I know some patients are on, and the cocktail that Ellie
think in its basic components, in the things that I prescribe, CoQ10, vitamin E, carnitine, it's highly appropriate. If the recommended doses on the labels don't work for everybody, that's why we measure levels, but I think Mitospectra is perfectly adequate.
It has all the same things.
It has, there's variations. There's, I mean, it has the key components. And in this age of very unfortunate and very incredibly difficult insurance issues, and I'm not sure how many of you are dealing with this just completely frustrating issue with getting things covered by insurance. I hate to say this, but it really has come into the thought process that if we don't know something's working and families are bankrupting themselves on vitamin cocktails, it's something we really, really have to consider. And Mitospectra is a great alternative to that. Over-the-counter supplements are a great alternative to that. I really recommend you speak with your physician. If this isn't being covered, if this is not something that's sort of tenable for your situation, there are definitely ways around it, and we just have to consider all that. All right, well, you're all welcome. I don't know if my contact information is anywhere, but everyone seems to find me anyway. So. All right, well, enjoy the rest of your conference. This was a pleasure.